insulin opens the cell up. So insulin opens the cell up, everything goes in. Glucose, nutrients, amino acids, and whatever else is in the bloodstream goes in. So if we starve the person of glucose, and we simply are using insulin in a fasting state, and we bring that blood sugar down into the 30s, and with insulin, we've now opened those cells up.
Welcome to What I Wish I Knew, a Cancer Starter Kit podcast, where I share everything I wish I had known after getting diagnosed. In this episode, my functional medicine doctor, Dr. Dan, sits down with other functional medicine doctor, Dr. Winkler. They get really deep about the variety of treatments available to patients. What I wish I knew about options are, number one, I have freaking options. When I was diagnosed, I was like, what I heard was you have two options and they both might kill you. But after so much of my own research, I really uncovered the wide array of treatments and the combination treatments that existed and that I really wanted to try. Number two, I remember going to a hypnotist shortly after I got diagnosed. I told you I tried everything. And she was like, if you don't think a certain treatment's gonna work, it's not gonna work. So you need to believe in whatever pathway you choose. Number three, you're the only one that gets to decide what direction you want to take your treatment and what it looks like. So have ownership over it and feel empowered to make that decision. Here's the episode.
Dr. Winkler, thanks for being on.
Glad to be here. Thanks so much for having me.
So tell the audience a little bit about who you are and what it is that you do.
So I'm a traditionally trained MD, and I got into integrative medicine about 20 years ago, and I decided to go down the integrative cancer treatment route. And so I've been doing integrative cancer treatments for about 20 years and focusing more on all these integrative things. So naturopathic physicians will call me a naturopathic MD because I'm more naturopathic than I am conventional. So
Definitely.
yeah.
And then what led you down medicine in general? And then on the flip side, what led you down cancer specifically?
So I've had a lot of different things I've done in my career, but all along I wanted to do something integrative. So even in medical school, I was interested in acupuncture. And so right at the University of Maryland, 20 minutes south, was the School of Oriental Medicine. And so I would sometimes go there and listen to lectures just because I wanted to hear something different. So I like that acupuncture. I like the sort of body, mind, and spirit type medicine. And I wanted to just learn more. So I then spent time learning nutrition. I spent time integrating nutrition into my practice. And as it kind of continued to develop, I really started saying, hey, I'm really done with prescription-based medicine. I was making house calls and home elderly for at least 8 years in the San Diego area. And I said, okay, it's probably time to shift out of that a little bit. And it was right around the same time that my mother-in-law came down with pancreatic cancer. And she wound up passing away from that. But the questions I started asking was like, wow, can this be done any better? Can it be done differently? Can it be done better? And I've been on that sort of journey to answer those questions. It's like learning about how cancer develops, how can cancer be treated, how is it treated conventionally, and then how do you treat it from a different perspective?
I think let's just dive right into those. I'd like to start with the RGCC, the liquid biopsy. Tell us what that is, a little bit more about that.
RGCC stands for the Regional Genetic Cancer Center, right? And so they're a lab in Greece, and that lab will provide, studies for all across the world. So it's very nice that we have that advantage that we're able to use that here. You can use it in Europe, Africa, wherever you are. So what that does is using blood work, and from the blood, they'll extract out the circulating tumor cells. And from the circulating tumor cells, they have a methodology that replicates those cells. And now you can develop multiple cells. And from that, they can develop and do different testing with petri dishes. So I said, put the cells in a petri dish, give it a chemo agent, and see whether the chemo agent is actually doing something to that particular line of cancer cells. So that's the liquid biopsy part is then the identification of those cells. So they can also identify, hey, we see these circulating cells, what are they? So there's an oncodeclare, and then the oncodeclare will tell you, hey, we're seeing circulating tumor DNA. So then we do an oncotrace. The oncotrace will tell you where those cells are coming from.
And that's all part of the same test.
That's all 2 different tests.
Got it.
Right. So the OncoDeclare says yay or nay, you have cancer. If it says yay, you do, then we got to go into the OncoTrace to then say, where is that cancer coming from?
Mm-hmm. And so the point of doing something like this, I'm assuming, would be more of an early detection standpoint.
Correct.
Where you're, drawing blood and just seeing what's going on versus waiting till you have symptoms per se.
Correct. So the nice thing about technology that we have today is obviously biomarkers, and this is one of those tests.
Mm-hmm.
So we can figure out early on, or you have concerns, or you run a family history of cancer. You may say, hey, I'm kind of concerned. Let me alleviate my peace, give me some peace of mind and figure out if it's positive or negative, because then, of course, you can get to the very early detection, which is the easiest way to treat.
So what types of cancer would this pick up? What would it be most useful for?
Yeah, most types of cancer, from my understanding. I'd have to go back and ask which ones it does not necessarily pick up very well. If there's a concern, we know the Gallery test. We've used the Gallery test because that will pick up some of the more dangerous, hard to treat cancers like gallbladder and pancreas and ovarian. So it picks those up, but doesn't pick up breast and prostate as well, where I believe the OncoDeclare, OncoTrace can pick that up much better.
Got it.
But I don't know if there's any limitations to that technology. So I think years ago we had patients with cancer of unknown primary, and we never really found out where, but I know that technology has improved. So what's sometimes nice is to know, it's like, hey, I've like somebody right now has a prostate nodule and they want to avoid the biopsy. And I'm like, well, if we don't want to know 100% what this is, we can get the PSMA scanned, see if it shows up someplace else, or if it's just active, it's most likely a cancer. And then we can look at the OncoDeclare or the OncoTrace, because we know there's a prostate origin, so we can do a prostate OncoTrace. And that would tell us more about what the characteristics are of those cells.
Interesting.
So there's a variety of cells, and the other thing that RGCC does is very nice, is they can tell us what the natural substances are that are best to use to treat those line of cells, and what are the best chemos to use.
Natural substances meaning, what are we talking about here?
Supplements, repurposed medications, which would be like your ivermectin, fenbendazole, but we could use DCA, OAA. Is there a benefit to using artesunate, curcumin, quercetin, apigenin? I mean, there's just lists and lists.
Using this on the actual blood, and they're seeing what?
They're using on the actual cells, correct. So those cells they're looking at death rate or effective rate of 2 days, I believe, and then the cancer cells with chemo is a 6-day rate. So then you get kill rates in the 70 to 80%, and then you look at those and you kind of come up with combinations from there. So that's how we use that test.
And so to reiterate, who would benefit from this? You're kind of saying people with a family history, if you're especially concerned that you might have cancer, more of a preventative measure.
Right. So for those that don't have cancer, this would be the beneficial test. You do an OncoDeclare and at least say, okay, we see that there's some circulating tumor DNA in there, and we can go further. So it's a test to find out from a preventive standpoint.
Got it.
Right.
And then generally speaking, what is the cost? Is this, I'm assuming this is probably not insurance covered at this point.
Depends upon the test. If remember, there's lots of different tests that the RGCC lab does. The main cost on some of those labs can be about $1,000, $1,200, and that's just for the OncoDeclare or for an OncoTrace or an OncoTrail. Any of those things are about that cost. The more sophisticated tests that are looking at sensitivity to those cancer cells, those are running $2,500 for natural substances and probably over $3,000, $3,200 for looking at the chemo and the natural substances.
Got it. Okay.
So it's about where the cost is on that right now.
Okay.
Yeah.
And then I know we were talking prior to recording about the fractionated chemo insulin. Can you tell us a little bit more about what that is?
So there's a little history to this. And so the original name was insulin potentiation therapy. Then it became insulin potentiation therapy low dose, or low dose chemo delivered by insulin potentiation therapy. And now we call it fractionated chemo with a bioresponse modifier. All right. So insulin being the bioresponse modifier, I know it gets a little
Mouthful.
wordy.
Yeah.
It gets to be quite the, so we still very, very easily in conversation, we'll just say IPT.
Okay.
So that just basically means that we're using insulin to open up the cancer cells to drive chemo or other agents into that cell, into those cancer cells. So the physiology is that the cancer has 16 times as many receptors. So if you were technical, there's growth receptors and insulin receptors. So combining growth receptors and insulin receptors or growth factor receptors, there are a total of at least 16 times as many. And that's why we see PET CT scans lighting up for tumors. Okay, so you have an uptake of insulin. Insulin opens the cell up. So insulin opens the cell, everything goes in. Glucose, nutrients, amino acids, and whatever else is in the bloodstream goes in. So if we starve the person of glucose and we simply are using insulin in a fasting state and we bring the blood sugar down into the 30s, with insulin, we've now opened those cells up. Patients have a response. They're usually going to get a little hot, a little sweaty. And then we say, okay, that's a therapeutic moment. And we then inject our treatment right on the spot.
The
One right after
chemotherapy.
other. Could be chemos and other agents, yes. So we can give those right on the spot. We give them a little bit of green tea, a little sugar in it, and just bring that blood sugar back up again to 70 to 80. And then we have other therapies we do after that. But that's part of the insulin potentiation process. We first bring the patient in a fasting state, lower the blood sugar, give the agents we want to give, and then bring the blood sugar back up again. It runs about an hour and a half.
So I guess the next question would be, why do that versus, traditional chemo?
Right. So chemo is a poison. It's a poison to cancer cells, but it's a poison to healthy cells as well. So by trying to isolate out the cancer cells with the insulin, we are raising the potential of those cancer cells the agents going to those cancer cells versus going to the healthy cells. So that's why it's potentiated. Insulin opens those cancer cells. So for example, they did studies on a breast cancer line of cells. And when they put methotrexate, a chemo agent, into that petri dish with those cancer cells, nothing happened. When you dropped a little bit of insulin in there, those cancer cells sucked up the methotrexate. So they'll take up that chemo preferentially, and chemo does have a damaging effect to those cells. So you're preferentially trying to kill those active dividing cells in the tumor versus trying to hit as many of the healthy cells. Now, we'll never say this is free of side effects. You're giving a chemo agent. We're just giving 10% dosing on average, 10% of the standard dosing. And then we just give smaller amounts more frequently. The body can handle that better. From my experience, that the body handles it much better than when I see patients that have gotten full dose chemo and their bone marrow gets suppressed, their hairs are falling out, they're throwing up, they have a lot more side effects. So we're trying to mitigate side effects by using a lower dose and getting more of that chemo to those cancer cells. And one of the things you have to think about is at any given point in time, a tumor is replicating, and there's only about 2 to 3% of those cells that are replicating. And when you give insulin, you stimulate growth. You're stimulating that replication, so you increase the replication rate to about 5%. So essentially, you're killing more cells with a lower dose, and you're stimulating those cells into a more chemoreceptive state. So the chemo, you push those cells, and we'll take the chemo in, versus a somewhat dormant cell that's just going to sit there and not do anything. So we're potentiating that effect as well.
Is this done in conventional medicine typically?
No.
You would think that it seems like it would be picked up. It's,
So remember, medicine is very pharmaceutically based, correct? So if I'm giving a 10% dose of a certain agent, am I likely to get a lot of pharmaceutical reps coming to my office, other people promoting the medication, or even a pharmaceutical company go, oh yeah, we're interested. We want to see how you can do a 10%. You're not going to get people interested in it. So we don't have the long-term studies, but we have enough, quote, anecdotal evidence to show, hey, this is working. We know the physiology. And in medicine, we have to be aware that everything isn't based on double-blind placebo-controlled studies. That's really should not be the standard. It should be based on how do we potentiate the physiology of what we know is happening. Can we benefit the biochemistry of the patient, the physiology of that patient, and not just going after, pharmaceutically based high dose agents that have side effects. Even some of the modern monoclonal antibodies, we modify the dose. So we try to mitigate side effects. So agents work. It's just sometimes, how do you deliver them? How often do you deliver them? Are there ways to do this a little bit, quote, better? And we call this more the kindler, gentler approach.
I see.
Right?
Are people still losing hair with this type of low dose chemotherapy?
Some thinning.
Some thinning. Okay.
Some thinning.
Okay.
So one of the key things is that if somebody is nutritionally doing very well, their GI tracts are working, they're functioning, absorbing, digesting, which does not happen quite frequently in, let's say, stage 3 and 4 cancers, right? So, but those people are more apt to side effects. So we spend a lot of time nutritionally building these patients up first, getting them into a good metabolic state, so that when they're getting hit with these agents, we see less side effects there.
I like that philosophy.
Right.
Yeah.
So it makes more sense, right?
Yeah.
Get the patient prepared for what we want to treat them. A lot of times, if they're losing weight, no, we're not seeing you, because that puts them into a dysaerobic state, which is a tear down state. It's a catabolic state. So if they're catabolic, it's not a good place to be treating. So we like them into being a normal state or more anabolic, right? Building back up again.
Maybe touch on, obviously we're giving insulin in a almost already a hypoglycemic state. How do you mitigate against hypoglycemia? Different effects of that.
The physiology of the person will actually respond naturally. So if they get into a certain level around 35, 45, the body will begin to react, right? The brain's going to go, no, I'm not comfortable with that. Releases an adrenaline. The patient gets hot, sweaty, flushes a little bit. The glycogen's being released from the liver. The blood sugar would slowly on its own come up again, but we only keep them there for several minutes. So it's just 2 or 3 minutes. We infuse, and then we give some other additional agents, and then we bring the blood sugar back up again. So it's tiring at best, but there's no long-term detriment to giving insulin.
Got it.
Right.
And any particular types of cancers that this type of therapy is more beneficial with than others that you've seen in practice?
Yeah, so the key thing is to look at the PET CT scan, right? The PET CT scan gives a shot of glucose that stimulates insulin production. Insulin goes and opens up the cancer cells. That tagged glucose now gets absorbed into the cancer, and then the machine will then give us 3 values, right? Where is it? How big is it? And what's the standard uptake value? And it's the uptake value that's important. So normal cells, let's say the heart or the liver, are a little more active, so they'll be around a 2 or 3 with the standard uptake value. Depends on the machine. They'll tell you in the report, right? So they'll say bone was 0.9, or let's say liver, 2.5. So the more active that cancer cells, the cancer has a standard uptake value, or an SUV of, let's say, 10, 12, 15. Those are more active cancers. Those are going to gobble up the glucose and the insulin much faster. Let's say you have a cancer cell that's like a 3 or 4, you're like, this isn't very active. So we try to treat it a little bit slower, maybe find other agents to use as well for that.
And I guess on that note, I'm not sure if this is going to make too much sense, but would those cancers that have higher uptake values, would a ketogenic style diet, lower sugar, be especially helpful for?
That would make sense, right? You're trying not to stimulate growth. Obviously, high carbohydrates and insulin, hence insulin production, would be more stimulative to that cancer. So then, yes, we like to put people on the diet. We make the diet more appropriate to the patient, right? So let's say somebody's, 5'2" and weighs 90 pounds. I'm like, I really want them on a keto diet, right? But if somebody is, 150 pounds and they're 5'2", I'm like, well, keto could work well. We'll lose some weight. You'll get some other benefits to that as well. So if they're underweight, I'll use more paleo type diets.
Got it.
You got to get some type of carbohydrates in there, right?
Got it.
Because remember, insulin is still the best growth factor for our body. Even if you are healthy, you still want insulin, because that's going to help grow. That's going to help keep stimulating growth, particularly if you're into bodybuilding or weight gaining or whatever you want to do. You're going to want some level of insulin production, not excess. It's always about balance, right?
Right. Anything else to note about that before we move on?
Well, the insulin potentiation therapy has really come a long way in terms of other agents that we can use. So I'll use other agents that are more metabolically blocking cancer. So we can use dichloroacetate, oxalacetate. I've done some work with methylglyoxal that was around many years ago. I've looked at the use of that, particularly seems to have an effect on brain tumors. There's some oral agents, so you can actually use some oral agents. Right when we give insulin, we'll give an oral agent because it'll be right at that absorbing time, 20 to 30 minutes, when the insulin level is sort of peaking in the treatment. So we can get benefits to that as well. And we do give a little bit of ivermectin to most of our patients at that therapeutic moment. And we also will use some off-label medications. We know that Claritin is helpful for basically enhancing the effects of chemo. So we look for some synergy. So our protocols will always evolve, and we use some different forms of medications for some synergistic effect, and we'll use even peptides. IRGD would be a really peptide that enhances the chemo effect as well. So
maybe talk a little bit more about ivermectin in general, because I know that's been a medication that's been thrown around, alternative medicine and cancer. I had a patient who was on it a while back. Maybe, talk a little bit more about the mechanism of that in general, and then also with what we were just talking about with the potentiation therapy.
I don't remember all the mechanisms of ivermectin. What's nice about it is it's been around for a long time, low side effect profile, it's inexpensive, and it has an effect on the spindles inside the cell, from my understanding. So it doesn't allow the cancer cells to grow and replicate. But it doesn't work every time on every person in every situation. And I think that's where the problem is. Because people walk in and go, well, I got cancer, I'm just going to go do ivermectin and fenbendazole. I'm like, well, let's see whether are those the right things for you. Is your body in a good state for really getting healthy? So we have this thing in our mindset that, I got sore throat, I get antibiotics, I'm fine. And cancer isn't that way. You can't just simply going to go, well, I got cancer, I'll take some ivermectin, fenbendazole, I'll be good. It's more about trying to figure out what's going on with the person. There's 27 different characteristics that happen in a cancer patient that we need to address. So it's not just ivermectin, fenbendazole. It's like going back and saying, what's going on with your metabolism? What are the triggers are there to this cancer? What else is happening to you metabolically, physically? What are the things we want to break down? So I spend a lot more detail on patients. And then we go back and find out, are there other medications that we can use, not just ivermectin? If it's ivermectin, fenbendazole, great. Then some like to do high dose. I'll kind of graduate the dose. I don't think these medications are completely benign. In fact, earlier, today I was looking at somebody's cell count. I'm like, why is their CBC showing low platelets? Oh, well, we've got them on an antiparasitic. And you have to keep track. It suppresses the bone marrow, can affect the liver. We see liver enzymes go up. So it isn't simply taking a high dose. So if you weigh 150 pounds, you can easily do 18 milligrams of fenbendazole. 18 milligrams of ivermectin. And you can fairly do that daily. Some do protocols where it's 3 out of 4 days or every other day. I usually just test out with each patient. What's the best dose for them? Is this the right dose? How often do they take it? And then do they need to stop after 3 weeks? Is it a 3 week on, 1 week off? Or is it going to be good? Because ivermectin will generally, from other sources I've read, it will only be good up to 6 months. So you have to start switching it. So remember, cancer, once you start giving cancer the same thing over again, it kind of outsmarts it after a while. It goes, okay, thanks. I've been seeing this for a while. I'm going to redirect my metabolism into something else. And then all of a sudden it stops working. Right.
Interesting.
And there's some synergy with fenbendazole. Now, just so fenbendazole, we always tell patients this. We know that it's out there. We know people are buying it. It's not an FDA-approved medication for human consumption, but nobody really cares. They're going to get it. They're going to use it, right? So they go to the vet and they get their vet supply stores and they get their fenbendazole, And so I just make it a point to just kind of know the dosing and just know what's safe with them, and then test out the dose and just have them use that. And then again, checking labs. You just can't simply just think you're going to be on your own and you're going to do fine. You're missing a lot of just using those two. So again, people know about it, and thanks to Mel Gibson, I had a few friends that got better on ivermectin. That's not the greatest way to look at it. And there's a lot more to cancer that meets the eye, and it isn't just simply, oh yeah, take these two
Sure.
medications and I'll be fine.
Yeah, I think there's a lot of black and white thinking in our culture and
Right.
medicine, alternative medicine, either, all for chemo and radiation or all against that, at all cost. And I think that's kind of not a fan of that black and white thinking myself. I mean, it's, it could be really detrimental, and you're missing a lot of these nuances and
Right.
these different types of, interventions like you just mentioned with the low dose chemo, but it's potentiated with the insulin,
Right.
much more effective perhaps in certain types of cancer. Yeah, I think it's, yeah, to your point. I mean, hopefully we're learning as a society.
Be nice if we can get people to think about it a little bit more comprehensively.
Mm-hmm.
If I take the liberties, one of the things we're seeing a lot of is toxicity.
Mm-hmm.
And so nobody ever thinks that they're toxic, and yet they're incredibly toxic. And you have to say, well, I got cancer. Is toxicity one of my problems, right? So toxicity leads to infections, leads to DNA changes, leads to blah, blah, blah. And the list, you could just keep going on. And so we're just finding on a consistent basis. I had 4 patients, and I even said to my nurse, I said, these are 4 of our most difficult patients. And I think even from an emotional standpoint, that the increased toxicity makes their thinking difficult.
Mm-hmm.
They're hard in terms of like getting them to understand what we're trying to tell them.
Mm-hmm.
And that really goes back to, hey, we've got BPA in our system, we got glyphosate, we got pesticides, you've got mold toxins in your body, and then you're wondering why you react to everything anybody ever gives you, and you've never looked at the fact that you are incredibly toxic. No one's ever properly detoxed you. And so we've worked really hard on cleaning people up and making that part of their treatment protocol. So if they're cleaned up, those metabolic pathways can open up again, and we can give them other things and try to preserve liver and, liver integrity, bone marrow integrity, so we don't see the side effects.
How would somebody know if they're toxic? Is everybody toxic? I mean, we're, in a very toxic world. We're exposed to a lot of toxins, no matter really how healthy we live, to some degree. I think there's a lot that's in our control, our water supply, shower water, our food that we eat, etc. But how would what are maybe some signs, of toxicity? And then maybe I'd love to get into some of those tests that you do on people, and maybe what percentage of people that have cancer have these common toxicities.
So I would assume you're toxic until proven otherwise.
Mm-hmm.
I mean, I don't really call Southern California air the most purest of air. I mean, we see some of the streaks in the skies. And, and naturally, what I've looked at is for over 20 years now, we've done a provocation for heavy metals.
Mm-hmm.
And that provocation would be with using EDTA. So it's an IV chelating agent. We just give that IV, provokes those metals out of the tissue into the bloodstream and into the kidney, and it's washed out, and then it gets into the urine, and we collect the urine. So years ago, we didn't see a lot of it as much, and we still saw, aluminum, cadmium, okay? We would see lead of everybody, nickel, be a lot of fish, we saw mercury, and we see a little bit of uranium, but not much of the others, right? So 2013, we started seeing cesium. I'm like, cesium? Oh, Fukushima, radioactive cesium. Which way does the water drift? It drifts to the west coast. So if that's the case, the fish is all contaminated. And if you're out there surfing and swimming, you're probably being exposed to some level of that water, right? So cesium levels were going up on people, right? 2015, I'm looking at these things, and I go, where are all these metals coming from? And we were seeing thorium, tin, uranium, barium, more aluminum, and a few other metals. I'm like, tungsten. I'm like, where is this coming from? Because I've done this now for 10 years now. This is another 10 years, 20 years of all this information. I'm like, well, where is this coming from? And then I started noticing that it became almost a rubber stamp. I would see the same on everybody, regardless of where they lived in this Southern California area, whether you're LA, whether you're East County, South Bay, North San Diego County, or if you were the Inland Empire, everybody had the same. Like, whoa, what is the common variable here? Well, it's either the water, right? So that, or it's the air, right? Because the air will drop whatever chemicals it is into the soil, and then it gets into the food. So now that's the other variable. So we're seeing, and so barium makes sense because barium, when you expose radiation to barium, it turns white, right? It looks white on an X-ray. Aluminum absorbs moisture. Aluminum hydroxide absorbs moisture. And then why the others are in there, I'm not really sure, but I will tell you on a consistent basis, I'm like, where's this stuff coming from? So I don't think it's coming from the sky. So I always tell people, you're toxic till proven otherwise. And all the food that we eat, all the grains that get harvested, they go to a silo. Well, silos aren't dry. All that moisture accumulates, and what goes with it? Mold. And so mold gets into our food. So you have mycotoxins, a byproduct of this mold, mycotoxins. These destroy your immune system. These can cause cancer. They can cause liver injuries. They can cause kidney problems. They can cause heart problems, whatever. They are just a huge, huge problem. So I will tell you, unless you think your mom lived in an isolated area, drank pure water, and ate pure food, and she wasn't toxic when she had you, or was carrying you, you're toxic, period. And I can't tell you anybody who's not. And I will tell you that cancer patients are more toxic. So then that begs the question, why are they more toxic than other patients that don't have cancer? So is there some metabolic pathways that are being hindered, or that they don't have, that they can't clear this stuff? It is causing more damage to their bodies. And that's kind of the next level of testing that I'm doing right now.
A lot of questions there about that.
I can tell you how we get it out. What we do is how we provoke it out of the patient is we will use the EDTA, and then we'll use some phospholipids, phosphatidylcholine. So we use Essential, if you're familiar with that. Essential is a phospholipid, which is the outer coating of a cell membrane, right? So it makes whatever comes in after that Essential is now more liposomal. So that opens the cell up. Glutathione comes afterwards. That helps the cell purge. And we are getting readings like you wouldn't believe. I mean, I've actually taken patients from other clinics, and I said, hey, I'm going to repeat this test, but here's how I'm going to do it differently. And then we're going to look now like, whoa, night and day difference. And I have 2 ladies from the Ukraine, and another third one is going to be doing this, and the amount of toxicity is off the chart.
So, and why is that a problem? Why are these heavy metals problematic in the context of cancer?
I think it's blocking metabolic pathways, so in other words, generation of oxygen, and keeping the Krebs cycle, energy production, and oxygen utilization at its optimum. So, and I think it's damaging cell membranes, so it damages the mitochondria, and the mitochondria, as they begin to deteriorate, then you wind up shifting to that cancerous type cell, right?
Multiple mechanisms here.
Right. So I think, if you look at Thomas Zeifri's work, cancer is a metabolic disease, right? So he was all about mitochondrial function. So, right. So you take the nucleus of a cancer cell and put it in a nucleus of a normal cell, it's going to turn normal. If you take the mitochondria from a cancer cell, actually take mitochondria from a normal cell, it becomes cancerous. If you put it in a cancer cell, I mean, the technology is pretty interesting. I have to go back and I don't figure out what I said was correct or not, but essentially, it's the cancer cell has a certain amount of processes with its DNA processing and how mitochondria are functioning that will cause deterioration to the cell. And that's where those toxins are working. So if you look at like Lyme, right? So we know Lyme thrives in patients who have mold, but mold creates the damage that Lyme lives on. So we don't treat Lyme with antibiotics. We treat Lyme by cleaning up the microenvironment of the body. And then the Lyme gets better. Then we use ozone. And ozone therapy and EBOO, extracorporeal blood, ozonation and oxygenation. We use that modality to help these patients get better. And we'll see the energy levels and how they feel. It just starts skyrocketing. Detox them, EBOO, and then we start seeing some real improvement.
Which was actually my next question. So, talking about EBOO, which you just mentioned is extracorporeal blood oxygenation and ozonation. Maybe talk a little bit about that, because that's something that maybe some of the listeners have not heard of, versus I think more widely thrown around term was just regular ozone. So maybe talk about what is EBOO, what is regular ozone, and then why might you want to use either therapeutic intervention.
Right. So starting with just ozone itself, or let's starting in the category of oxidative therapies, right? So oxidative therapies means you're delivering some form of oxygen, right? Even vitamin C has an oxidative capacity, right? It goes inside the cancer cells. It's reacting with iron. Okay. So it's doing something oxidative. Oxidative means essentially you're stealing an electron, right? So if you're oxidizing, you're reducing something, you're giving an electron, you're oxidizing, you're stealing an electron. But ozone has the ability to donate electrons. So it's healthy, but it also adds oxygen to a cancer cell and oxygen to the body, because people that are sick have low oxygen states. If you ever notice their blood is very dark, and after you give ozone and after several treatments of those, it's not quite so dark anymore. So they're getting better oxygen carrying capacity to the cells, and the ozone reacts with inflammation. It travels throughout the body and it finds inflammation. In fact, I did that on myself when I herniated a disc one time and I ran a hydrogen peroxide IV. I was like, why is my back hurt? And then we turned the IV off and the back pain went away. Turned the IV back on again and my back pain hurt again. So I still had too much inflammation at my disc level that was causing pain. So these things find their way in the body to go where the inflammation is. So these are powerful treatments. So we couple that with various forms of ozone. You can simply take some blood out, mix it with ozone, and put it back in again. Right? And ozone reacts immediately. Even though it's a gas, it reacts immediately. You'll see the blood go from dark to being bright red. There's another device we have, the Zotzman device, which essentially you can pull out half a quarter blood at a time. You can ozonate it, and then you run it back in again, and you can do that as many times as you really want. We start people at 3, 6, get them up to 10, see how they feel. Because there's a potential for a reaction, right? You kill too much, you clean up too much at once, you're going to have a potential Herxheimer reaction. So you get achy, you don't feel well, you can be flu-like. So we try to avoid that, but we also tell you how we treat that. So we can, and the same thing is now EBOO is going to be one where you can start with just oxygen, right? So you're running. It's a little harder to do because you're running 2 IVs, right? One is the blood's coming out and the other arm, the blood's going in. So you're standing there like this. So you got 2 arms kind of tied up. You're pulling the blood out. That blood will now be filtered. First time they'll be oxygenated and then put back in again. The next time you're going to give a small dose of ozone, 3.5 gamma, just a measure of ozone, and then see how you do with that. Can we do the full treatment or do we do 20 minutes and we build up on that treatment? Depends how the patient responds. So they'll tell you pretty quickly if they're not feeling well with it. And then we build up to 7 gamma, and that's for the full treatment. And that's when you start seeing people feeling really well. So that's, for me, I think it's a plus to add that to most of our cancer programs, cancer treatments.
Which, the EBOO or the ozone?
Well, EBOO or some form of ozone. But one of the caveats that you have to be aware of is that if patients are in an anabolic state, right? So the cancer can control your metabolism, and putting you in an anabolic state is a growth state for the cancer, right? But if your body is like, if you're losing weight, your energy's low, you're getting into a catabolic state, that's also called a dysaerobic state. That means that every time you breathe oxygen, you breathe air, you are rusting, you're oxidizing. That state would not benefit from more ozone. That would make them worse. So you have to be aware of that. So we check our patients to make sure they're not in a dysaerobic state, because if they are, we don't want to give them ozone. Then we give them an antioxidant, and we work with antioxidant treatments and get their bodies back into a more balanced state. And then if they're anabolic, they can certainly handle the ozone. It actually helps heal the anabolic state. So we have to be aware of that little caveat. And that's some in-office testing that we do. So once we have that, we will treat them, and then we just increase it and retest them, retest. You want to make sure that we're keeping them in a healthy state.
And what kind of testing, if you don't mind sharing, are you looking at to determine that? So I did a lecture a couple of years ago, and the person I'll give credit to is Dr. Guy Shanker's a chiropractor in Pennsylvania. Nutrispect is his company, nutrispect.net. And he's taken a lot of Rabici's work and a few other people's work and just made it into something very simple and practical. So when you do a urine test, you do a urine dipstick. If somebody has a concentrated urine and a high specific gravity, they're very likely to be
So highly concentrated, high specific gravity, low pH, they're acidic.
Mm-hmm.
They're likely to be in a dysaerobic state. If they have a low specific gravity, in other words, the urine's more dilute, and they have higher pHs, they're more apt to be in a anaerobic state.
Mm-hmm.
So we use that, and there's a few other measures that you can do. It's a very easy course for most practitioners to learn.
Anabolic or anaerobic, Jay?
So anabolic and anaerobic go together,
Mm.
and catabolic and dysaerobic go together.
Mm.
So there's basically two ends of the pendulum, right? So we want to know where you are. We like people to be normal, but they're going to tend to be one way or the other.
Mm.
And once once they're anaerobic, we want to shift them back, and if they're dysaerobic, we'll shift them back.
Got it.
Right.
Got it. And then if I missed this, the instances where you'd want to use something like EBOO versus regular ozone, 1 pass or 3 pass. You were mentioning the different numbers,
Right.
as, passes of some people. For the listeners, you might have heard of a 10 pass ozone treatment.
Right,
That's
people
what
familiar with 10
Dr.
pass,
Winkler
or we
was
call
talking about.
multi-pass, correct. So a lot of it's tolerability. All right. So the more toxic they are, the less they'll tolerate. But as they begin to progress, they'll tolerate more. So we'll start lower, because the idea is, you don't want to make people sick in the midst of trying to get them well. Right. So hey, I had a really bad reaction to that treatment. Then we got to back off. So even our detox IVs, we start off with an A level A, we go to a B, we go to a C, and go to a D. But if you don't feel well, you got to go back. If something doesn't make you feel well, you go back a notch. And so we're trying to get people to work up to the high levels, because that just basically tells them we're clearing a lot of toxins out of their body and repairing. So the IV also repairs the damage, and that's crucial.
So many questions I could ask. I want to get into a couple more interventions, and I kind of want to zoom out and talk a little bit about emotions as well. I think that's a really important topic that I'd love to dive deeper into. But let's get into a couple more therapies. I know next one on my list was biomodulation or low-level laser therapy. Some of these, what are those therapies, and when are they most useful?
So we call photodynamic therapy, biomodulation. That's basically giving laser. And so lasers are light source, and light sources will stimulate certain compounds. All right. So curcumin, for example, we know is very anti-inflammatory, but if we boosted that with blue light or ultraviolet light, you would then get an extra burst to the effectiveness of that curcumin.
So you're talking about a curcumin IV?
Right. So look at you got some great veins, right?
Yeah.
So we essentially
I was the pincushion in medical
Yeah,
school.
I lost all my veins with IVs. So I'm looking at you going, you'd be a great patient. So we have a large catheter that will go in, and so the catheter would essentially allow the curcumin to come in, and then a fiber optic will go, and the tip of that would stick in your vein. Then you could actually see it from the surface, and we run light therapy. So sometimes we just did, let me use, for example, my mother, she got vaccinated, and her inflammatory markers literally went off the chart, and she was aching everywhere. So we started her twice a week, curcumin with the photodynamic therapy. And within a month, we literally saw that inflammatory marker like CRP went from 150 to 20. And then it kept coming down until she felt better. But it's a very powerful way to metabolically and physically change something, right? So in her situation, it was curcumin is anti-inflammatory. And so we were using it. We just stimulated that. We can even use, riboflavin, IV riboflavin. It's yellow. So yellow just stimulates that light, and it's just we're using that to reduce inflammation. You can run all gamuts of the light. Just put the laser in your vein, run the gamut of light, and you're getting a full energetic treatment. You're just stimulating energy in the body. So those light work, the actual lights work on the mitochondrial function. If you can keep track of all the different
wavelengths.
All the different cytochromes. So there's each wavelength has an effect on the different cytochromes in that electron transport chain, right? So those are energetically stimulating. If we have somebody, for example, we would use, let's say, some methylene blue, then we could photoactivate the methylene blue. We could target that towards a tumor. So that's another way of doing it. So let's say you can give the methylene blue with insulin, and that gets taken up by the tumor, and then you can come afterwards and laser it.
So you're talking about intravenous methylene blue?
You do intravenous
Okay.
methylene blue, and if you give it with insulin, we're targeting that towards the cancer cell, and then we can do laser. So we can do some interstitial laser or in the tissue laser. So that works very well on tumors that are very superficial. So we can do that on, let's say, breast cancer. All right, so we can put down the area up, and let's say have a tumor on the right side, we would put laser, a little needle with the laser in there, and then we give the photoactive substance, and then we run the laser to that area. So you want to run red light or infrared light to heat that dye up that's inside the cancer cell by way of destroying the cancer cell.
So that's you're going inside out and outside in simultaneously.
You can do that as well, yes. And then we have another laser, that's handheld laser, that we can just use from the outside. So sometimes we'll just inject the methylene blue in and around an area that we want to treat, and then we'll laser that afterwards. So that works as well. Yeah.
Lots of options.
It's a very unique therapy. I love the work. Right. So the best person is Dr. Weber, the German physician. He has a whole organization for the Weber laser. Yeah. And he's online. There's a ton of information to obtain. We go to his conferences on a yearly basis. Great information. And people are doing some really unique things for me, but like treating disc disease to treating joints. I've had several treatments for my knee as well as my shoulders. So it's really nice. So let's say you do a PRP injection into a joint. You want to keep the needle in, but put the laser in afterwards, and then photoactivate that PRP. Right. So that's a way to stimulate that PRP to work better. And we've done that quite a bit with some good success as well.
Interesting.
Knees, hips. Yeah.
I think I wanted to get into, immunotherapy next. Getting into that, low dose immunotherapy. If you could just touch on that.
Yeah, that's on the website as well, right? So the low dose immunotherapy, that's time instance work. So there's two physicians that developed this type of technique, and it's basically almost homeopathic in a way.
Okay.
So they give us vials, and you can order those vials, and then you have to dilute them yourself, and you dilute them homeopathically in the C format, right? So 100-fold dilution.
Can you explain to the audience what that means?
Right. So if we let's say take a milliliter of milk, right? So that's what's called the mother formula, right? Let's say we want to make a 10C formula, all right? So then you're going to take that 1 milliliter and you're going to dilute it to 100 milliliters. Large syringe, dilute it out, and then you have to succuss it. That's the key point. You have to succuss it 100 times. And now you have a 1X formula. So then I take 1 milliliter of that formula, and I dilute that 1 milliliter to another 100 milliliters
of water. Are you talking?
Water. Yeah, water, saline. And then succuss that 100 times. So you can do that 8 more times until you now have a 10C formula. So those dilutions are then used to treat a milk allergy. All right, so I use milk. I now have a dilution, and I can go up to, like, most of the formulas, I don't do much beyond 30C because it's just like this just gets so dilute, and I don't necessarily find I need to go beyond that. But we will use those formulas then to help people with eczema, psoriasis. So even food allergies, joint pains, Epstein-Barr. So we have parasites, mold toxins. If you're immune and reacting to mold toxins, the immune system's reactive. It's a way to calm the immune system down. And we're using these super dilute formulas. And there's actually, when you get to these dilutions, there's not much really in there. Right. So I always tell people this. I said, look, if you're allergic to milk and I give you a glass of milk, you're going to have a terrible reaction. But if I gave you a drop of that milk in a gallon of water and had you drink that water, you probably wouldn't react because it's so dilute. So then I basically create tolerance by now going, okay, the next form is going to be 2 drops. The next form is 3 drops. And we build on that tolerance. So you can become more tolerant to the things you're allergic to. I've done this on myself. I've used the food formula, and I noticed, and I said, okay, I'll be devil's advocate, right? So I started off with a 20C. I didn't react. And I said, okay, let's just see what happens. And I went down to a 16C. So it's a much more concentrated formula, and boom, the next day I have hives. I'm like, oh, great. Oh, I know where that came from. Never had hives before, I have hives now. And it takes the immune system about 7 to 8 weeks to begin to adjust to this, right? So then I stayed away from any more immune therapy, right? And wait till the hives, because every time I scratch, I got hives. So it's like, oh, so just obviously had to stop scratching and just, you can use some antihistamines, calm it down a little bit. So then after 2 months, I went and did a 20C again. And I went 2 weeks after that, did a 19C, and this by injection. So simply skin injection just into the top layer of the skin. I got down to 16C, and then I went all the way down to I think I got down to 6C. But I noticed my food tolerances that I had against dairy were better. If I would eat dairy, I used to get joint pain. I don't anymore. I also noticed that I could have other reactions to certain foods, stuffiness or something else, and that would essentially abate. And we've seen it over and over again with psoriasis, eczema. You find the right formula, and we use these dilute formulas, and then we increase the concentration by going down on the dilution. That makes sense.
Got it. So this is more for general health, food sensitivities, perhaps not necessarily cancer.
Well, we use people that are sensitive to, let's say they have dental work done. We have we have people with chemicals they've been allergic to. So I actually have used it a few times because we know that mycobacterium and the TB vaccine actually stimulates the immune system against cancer. So it's actually beneficial to build that up on people, but we just don't have that vaccine available anymore. At least not commercial. It's hard. The urologist will get it because they'll use it for bladder cancer, but it's really helpful in a lot of other cancers, and it's just hard to get. So I was using the LDI, the low-dose immune therapy with mycobacterium. I just haven't done enough of it to really see if it works or not.
And I think maybe the last topic that I want to get into before kind of zooming out, talking more about some emotions, diet, lifestyle, and then I think it would be helpful to kind of just talk about how you approach all these different options, because it sounds like there's many options out there that you could be doing, and kind of how do you, differentiate what's most important, or how do you kind of run through a protocol? I guess I wanted to ask about just IV therapy in general. You mentioned vitamin C. Those in the cancer world have likely heard about high dose vitamin C, or, mistletoe IVs, artemisinin perhaps. Maybe talk a little bit about what types of, regular IVs, I guess you could say, instead of ozone, but the vitamins, what, glutathione, vitamin C, high dose vitamin C that you use, and their efficacy.
Yeah, so there was a lot in those questions, right? So there's a lot of different ways to administer, let's say, mistletoe, all right? So mistletoe, we need to find the right mistletoe for the person who has a certain cancer type. So let's say metastatic cancer, we're always going to use a Fraxini because it's higher lectin content, it's higher immune system stimulating. If there's breast, we'll use Viscomali, I believe, right? So we use a different form of mistletoe that's specific to the cancer type. There's some that actually go a little deeper, and they'll look at the emotional constitution of the person and can add other things to that. So the mistletoe is intended to be given by the patient to themselves, or somebody in a family member can do that. And you do the injections. You can do it on your abdomen, do it on your thigh. It's just basically a way to start getting the immune system more active, right? So we start low concentrations. We build up on those concentrations. You follow the certain series. There's various series that we use. Series 1, Series 2, Series 4, and then you go to 50 milligrams, 100 milligrams. And then we do the intravenous ones as well. So those are trying to elicit some type of, maybe some fever, a little bit of temperature rise, because cancer patients generally are more on the cold side, right, temperature-wise. So the Viscom, these Viscom products, the mistletoe products will help raise the body temperature. And that's more of a warming therapy, right? So the other type of therapy we use as well is Helleborus. Right? So Helleborus is the Christmas rose. So what I like about looking at anthroposcopic medicine is that you look at look at the environment in which the plant grows. So if a plant buds in January into a beautiful white flower and it grows in the snow of the tundra, you're like, that's got to be a pretty hardy plant, right? There's something there that plant's growing and budding in the middle of winter. So I think the essence of that is intended to help patients that are weakened by cancer. So if you're in a weakened state, whether it's even from other diseases, hellebores is a great option. So we give it intravenously. You can do it nebulizer as well with mistletoe. We'll have them injected on a regular basis. We'll again increase the concentration and try to get it to higher concentrations to really boost people's metabolism and energy in their body. So those are those anthroposcopic formulations you kind of mentioned. We use mistletoe and hellebores. Love to dig deeper into that. We've been spending a lot more time. I think Nasha Winters wrote a really good book. I forgot the other guy's name that she wrote it with. But there's Steve, there's another, not sure, another ND that she wrote with. I think he's actually in Atlanta. So there's some good material available for that. And there's probably some helpful guides you could get off of the Elixir website. I think they have some information like patient instructions and things like that. So we'll use that. We also use a number of different IVs. So I basically, when I looked at this 20 years ago, I knew that there was a lot of chiropractors in Southern California, a lot of chiropractors, but they were doing nutrition. And I go, well, what is it that I can do that they can't do? And that was IVs. So I developed the IV center, and that was the whole intent. Well, what can we do so that I don't need to compete with chiropractors? I'd rather than be a referral source.
Right.
So send them to us for the IV therapy, and we'll send them back. They're all yours. So that I think worked really well. And of course, I won't hire a chiropractor for the reason that I don't want to lose that reference, that referral source. So the IVs that we were doing is basically trying to figure out all the things that are available that can be put into an IV. So there are obviously some simple protocols. There are Myers cocktails. There's amino acid drips. Now we have hangover drips. We have, these banana drips, whatever you want to call them. Everybody's got another drip that's going. And those are just simple vitamins, amino acids, maybe some low dose vitamin C in there, some minerals, there's all sorts of things that you can come up with. And we don't really spend too much time. Most of our patients are fairly sick. So by the time we're doing that, we're kind of stepping to the next level of using, let's say, poly-MBA, which we think is really helpful for our cancer patients. We'll add DCA to that and OAA. So now it's a cancer treatment and a restorative treatment. So we're trying to combine things. We'll use, I just have done so many over the years. So whether it's anti-metabolic cancer treatments, whether it's natural things, you mentioned artemisinin, we've given, we're doing a lot of ginseng right now. The ginseng is very powerfully anti-inflammatory. Interesting enough, it works at the cellular level to change inflammation. So that actually helps really quite a bit in cancer. So it's a patient that we're just like, hey, you're not feeling well, you're totally inflamed, let's just calm the system down, and we're giving them ginseng. And that seems to be working.
Never heard of that being given IV. Just oral.
Yeah, oral. Obviously, that's the most common way, but this is a particular IV form, and I understand they use some type of structured water that it's developed in, and it's fermented, so it's a completely bit of a different product. But the results, we're seeing the improvement. So that's really helpful. Because you hear it from the vendors, people we buy from, and you're like, well, okay. And then we see studies, and then you start trying to really develop these things, and a lot of it comes in from foreign countries as well. They're importing it. But there also a lot of the research has been done overseas. And I'd just say I kind of rely on that as well. You can't just use everything out of the United States.
Right.
So we go to various forms of other oxidative therapies. So that would be vitamin C. That we would start off with making sure everybody has a proper G6PD. In other words, that's a glucose 6-phosphate deficiency. I want to make sure they don't have that, so that it's safe to give higher dosages of vitamin C. So everybody gets that blood test.
Maybe talk about the ramifications of doing a high dose vitamin C in the presence of a G6PD.
Right. So
just for the listeners,
inadvertently, years ago, we saw this even on somebody with a G6PD deficiency that we gave even just a low dose of vitamin C. And it stresses the blood cells, that the blood cells will break open, will hemolyze, they'll break open. And you'll see the urine gets bloody, it looks like, oh shoot, what's happening here? So they get anemic if you do too much, right? So the blood, basically, you're breaking open the blood cells. They don't have the oxidative, the ability to reduce this oxidation that's happening. So they break open, they die.
Just
right?
a caution for the listeners.
It's
Please get
yeah,
that test
everybody
done
needs a
before
G6PD, right?
getting high dose vitamin C.
We're always around the office. They get a G6PD, they get a G6PD. So we always make sure that gets done and added to all the routine lab work. So we start off, years ago, we used to do 10, 25 grams, or 15 grams. So that's 15,000 milligrams, right? Anybody that can do that orally, God bless them. That's it's tough to get the amount. So when you take it at a low dose, it's an antioxidant, right? So and vitamin C really is ascorbic acid, right? So but it's not the accurate way, right? Vitamin C isn't really it's more of a group of chemical molecules, right, in nature, where we kind of all call ascorbic acid vitamin C. So let's be specific. It's ascorbic acid, right? So ascorbate, sodium ascorbate or ascorbic acid. It's just the same molecule, essentially what we're using. And then we start with, let's say, 15 to go to 25 grams. And we've gone as high as 25. I had one guy with prostate cancer. He wanted to go to 125, 150. I'm not a super big fan of thinking it works that great from our experience. I know people have had other experiences, and this recently I listened to a lecture, and I thought he kind of, Dr. Mitch Gann was talking about giving green tea and quercetin prior to the vitamin C to add, I think, oxidative stress to the system. There's some benefit to that. I'm like, oh, maybe that's why we haven't seen, the results that other people are claiming with the high dose vitamin C. So we've looked at other oxidative therapies in terms of selenite. Most cancer patients are selenium deficient. If you give selenite, it's basically selenium wrapped in a bunch of oxygen molecules around it. So it's delivering oxygen and selenium. It's like, oh, we've got a double benefit there. So that's another oxidative treatment. We've given that. We've gone with the big one right now is ozonated glycerin. So we know that glycerin absorbs ozone and holds onto that ozone. And you just keep it frozen. And then when you use it, you just put it in the IV bag and run it in. And so that's having some good effect as well. So those are some of the other IVs that we'll do in addition to vitamin C. Vitamin C, you can spend a lot of time on. There's some people that are still drawing blood levels, so make sure you're getting high enough, because you'll notice if you take a glucose check while in vitamin C, it's going to read all over the place. It could read 1,000. This is not accurate, because the vitamin C will react with the glucometer and it'll throw the blood sugar reading off. So there are other ways. We actually haven't had a device. We used an iStat machine, and that was the only way we could get the glucose reading while somebody was on vitamin C. So that was one way to bypass that. And so checking vitamin C levels, therapeutically adjusting it. Some people are really big into doing it. I just never found our patients were ever really coming in on a regular basis enough to really spend the time doing that. And it got to be very labor intensive, so we didn't do it. We give the 50 grams afterwards, and we just finished there. Right. So we do that after we do a chemo treatment. So if we do the low dose chemo, we'll finish it with a high dose vitamin C or ozonated glycerin or something else.
Talk a little bit about why you're doing that in that order, because I think that's important for the listeners. How do you stack these therapies to have the most, robust impact?
Yeah, it's a lot of that. That's where the word practice comes in. Why it's called a medical practice. So you'll see what patients react to, and patients know that, these are things that we're doing that are not always a standard of care. These are non-standard of care treatments. Right. And we talked about waivers, side effects, and we just kind of cautiously give things. If we start something, it's always a low dose. If somebody we think is very constitutionally kind of weak, we're going to a very low dose. Just want to say, hey, let's try a little bit of this and let's see how you do with it. And then if we know that somebody's a little more robust, we can say, okay, let's see if we can't, from basically a physiological perspective, that kind of makes sense to go with that. Like, I don't think I would give curcumin with then high dose vitamin C. They'll contradict, kind of counter each other, right? They would sort of block that effect. But can I give vitamin C with hydrogen peroxide, which isn't even available in California anymore, but when we were doing it, we would give vitamin C with hydrogen peroxide, so we stacked it. And that had an additive oxidative effect. So now we do ozonated glycerin. It's kind of interesting when the FDA finds ways to shut down what we're trying to do. We get more innovative and better therapies than what we've had before. And I'm like, well, it's interesting. It's like they're trying to slow us down, and yet we get, man's ingenuity is pretty incredible. So I don't think the government works that fast to keep up with everything that's available. So, but we were stacking those IVs. I won't think I would give hydrogen peroxide drip and then give glutathione after that, which just doesn't always work well. Some people have done it. It's a little more on the cautious side of that. I might give glutathione after curcumin. I would maybe give an oxidative therapy with another oxidative therapy, but I don't necessarily give an antioxidant with a pro-oxidative therapy, right?
Negating the
Right.
effect.
Right. And if you give me somebody amino acid drips and vitamins, I'm not going to give too much of an oxidative therapy after that.
Right.
I rather give, actually, I've got a few people doing ginseng with amino acids. So we can kind of combine those, especially if they need that nutritionally. Yeah.
To build them back up.
Right.
Right. Let's, I want to get into maybe a little bit about somebody comes into your office, they say they just got diagnosed with cancer. What is the typical pathway that they go through? I'm assuming it's a relatively in-depth consultation, figuring out a lot of things that you've mentioned, because there's so many different components of this. Their emotions, their toxicity, their diet and lifestyle, all these different factors that influence what's going on. But maybe just walk us through like an average or typical patient journey. They come into your office, they've been diagnosed with cancer. What does a typical workup look like? Maybe walk us through that process.
So we have a bit of a screening process. So I need to see like what type of cancer they have, like what they're looking for. So we have a little bit of information before they come in. It helps if they bring either their, significant other or a friend that can take notes. These consults tend to be very overwhelming, an hour and a half. A lot of people are already kind of stressed, right? So maybe they've heard from the oncologist. They've been sort of feared into, God, I got to do something. I'm scared. They're scaring me. I got to do something. So we have to kind of work through, hey, slow down. Okay, I had somebody had a brain tumor removed, and the wife was just like, oh, we got to get on ivermectin. This is, we're not going to end this guy's end date, right? So everybody has an end date. And let's start from there. Let's get the quality of life in order to get him to his best life. So I'm trying to figure out where each person's coming from to kind of reframe and get to the point where we're all thinking on the same page. And this is a fit. So that's kind of where the first consult comes in. And it's okay, here's some suggestions. This is what I'm thinking. These are some other ideas. But what I do then is I really have them go through almost like a 5-step process. And I just finished putting that up on YouTube. So we actually go through a number of steps. And so let's say we've established, okay, you've got a cancer type. I think we can help you. If you're interested, here's kind of the next steps that we want to do. So the first one is we do balance testing. Balance testing is looking at the 5 balancing mechanisms of the body, right? So most of us kind of know what they are, especially as a practitioner, you're going to be you'll know what they are, right? And we've talked about the anaerobic, disaerobic utilization of oxygen is one of those balancing mechanisms. The other's pH, utilization of glucose, minerals, and the nervous system. Is it sympathetic or parasympathetic, right? Is it fight, or is it going to be more of a parasympathetic, more relaxed state? So, or let's say one state's so weak and the other one dominates. So we have to kind of figure a lot of these things out. We do mineral taste testing in the office. We look for free radicals. We look for oxalates. We look for vitamin C levels, and we do a bioimpedance analysis. So we have a sense of what their cellular battery charge is, how healthy are the cells. So now we have a sort of an idea about their physical makeup, what are the mechanisms of action that are happening in this body. Okay. So then that's the first part. And then we'll go over that. At the same time as then they'll meet with my naturopath, and she'll talk about the lifestyle, the diet. I'll give them concepts in their diet, but then if somebody wants to say, hey, order this from this company, they deliver, this is great food, she'll figure all that out for them. I think I give something away. So then she'll work on that, and she'll also work on supplements to address those metabolic states. Then we go through a detox IV that I mentioned. So I want to see what their toxins are, because sometimes it's so toxic. I'm like, I got to detox you first before we get too much into treatment. And that's okay, because we can add more metabolic treatments to it, some things that will help support along the way as well as treat the cancer and then detox. So it's like, how do we figure this out? So that part gets done. Then I spend an hour just working through the neuroemotional level. So I'm going to figure out, I'm okay with getting well. I'm okay with God, God's okay with me. Are there any emotions attached to this cancer? Are there any other emotions, any other root causes? Where's the origin of that emotion? Right. So we're digging back into childhood. So I'll spend time in that neuroemotional realm, and I will use a variety of different techniques that I've learned. I like the neuroemotional, the Scott Walker who's developed the neuroemotional technique. That's sort of where I started with that. I use a little bit of Ruby Med with the vials for testing homeopaths, for emotional homeopaths. I'll use some of the emotion code. And there's just sometimes it's just intuitive, something comes up and I'm like, something's there, let's dig for it, and we'll pull stuff out. So I'll work that, and then that's pretty much a good hour. But most of the patients, if they're open to it, we're gonna break through some layers, which is usually crying, and it's like releasing, carrying this emotional burden for so many years. So we like to kind of release. Sometimes it takes more than a visit, but we can clear and get people more of an understanding of where some of this stuff's coming from. Where's the shame coming from? Where's this unforgiveness? And then I have, so now we've done like the in-office balance testing, we've done the IV, we've met for lifestyle counseling, we've done the neuroemotional, and we want to do some bioresonance testing. And that would be with whatever device. We have a couple of devices, and we want to look at what's happening energetically, give us a few more clues. And some of these devices actually will pick up where the tumor is. It's kind of interesting.
Really? Can you explain maybe a little bit more about what that is?
So bioresonance, there's a couple of devices we use. So the Quest 4 is the new version of the Asira, which is what I started with about 15 years ago. That's a device. You're holding electrodes and microcurrents going through you. And it's reading every one of your systems. It's reading all of your chemistry. And so what you have to understand is with these therapies is that everything should function on a normal resonance. All right. So a resonance, let's say I have a bell and I tap that bell, it has a certain sound, right? That's a certain wavelength and frequency. And then if I put a crack in that bell and now I tap it, I'm not going to get the same frequency, right? So the machine goes, well, okay, you're resonating at this frequency, you should be here, and this gap is caused by this imbalance. Whether it's an infection, is it just some hormone imbalance? Is it something biochemical? And so you can get a lot of energetic read off of what's happening with the person. The other device that we use is the nonlinear screening. And that's a very interesting one. You're wearing a headset and it's running, I believe, sound through some level of sound. You're not hearing this, but it's running this through your system. And it's picking up where the organ systems are stressed and where the metabolic pathways are stressed. And then you go back and then you ask, okay, what's causing this stress? And then you can do a blood analysis. Is there enough nutrients and vitamins and minerals in the system? Are there toxins in the system? And it gives you an idea, hey, these people are very toxically burdened. And you were seeing there's a lot of stuff here, or they're nutritionally very depleted. Right? Or you can even dig in there and ask if there's infections in the system. And it will, but based on frequency, pick that up. But then it goes back and if you program it correctly, you can go back and treat each one of those areas. If there's an infection you want to treat, and the machine will say, okay, from an energetic perspective, you went from 10% to 50%. You got a 40% improvement in this from the energetic treatment of this. And actually, what's really funny is that people that we've done that with will actually, if they don't manifest a symptom, they may manifest it later, and then the symptom will go away with the treatment. Or if they have symptoms, they'll feel better afterwards. And it picks up stuff that we don't always ask for. We've picked up a few sexually transmitted infections on some young people, and they're like, we didn't think to ask. That was a part of our interview. Now we're asking. So now we're asking these questions, and so it's kind of funny. It's embarrassing in a way because it picks up a lot of things, and it scales it on 1 to 6. So 1 being normal, 6 being there's a possibility if this could lead to something physical, and then you can energetically treat that. So there's a lot of utility to some of these devices.
So if I'm understanding it correctly, and I'm pretty green to that type of medicine. So each organ you're saying is going to be emitting a certain frequency. And so this machine would be recognizing that frequency of each of the organs of the body.
Yes.
And then therefore, if it's not producing that resonant or that healthy frequency, you're able to differentiate. Okay, the liver is problematic based on this test.
They'll tell you where in the liver the problem is too.
I see.
And it'll go down to the micro level and say, hey, this is the problem. And you got to go back and ask it what's that problem, what's causing that problem, and then go treat that.
Sounds kind of like the Rife machine.
There's some Rife technology we've worked with as well.
Okay.
Yeah. I'm waiting for the latest development on one of these engineers that we're working with to see what he's coming out with. But Rife technology is more also light frequency based, right?
So we're talking about how the device picks up, or how different organs in the body have different frequencies, and then how this device picks that up.
Yeah, I mean, that's probably more technical than beyond my understanding as well. But I understand it as a sense that anything chemical has its own frequency. Any organ system has a frequency, and if it's abnormal, the machine knows what it should be, and then it picks up, oh, this is abnormal. To what level is it abnormal? And then it goes back and says, this is potentially what's causing that abnormality. Got it. So I think that's based on the data that it has stored in it. Because I've looked at some of the older ones. I had a Hunter Metapathia years ago, and we still use it. My wife uses it, but I don't think it has the database that the newer one has. Sure. Because it was a more modern machine, right? So the only problem with this one is it doesn't really update its data. Its database, where the Quest 4 and the Asira does update its database. And it'll be interesting, just so you know, when I had COVID 5 years ago, that machine did not have the program for COVID, but it told me I had coronavirus. But because it had coronavirus, I can now develop a remedy off that machine to treat the coronavirus. It's interesting. So I did. So I actually took the plate and put it against my body and just ran the treatment. Energetic treatment was coming off the treatment plate. And then the treatment plate can also be used to imprint a remedy into a 20% alcohol solution. And so I was using that as well. And we do that all the time. So if we have a remedy, let's say these are all your imbalances. If we want to energetically fix that, the machine will imprint the correcting frequencies into this remedy, and then you take it orally, and it tells you take twice a day, 8 drops for 4 weeks, come back in 4 weeks, and we'll look at it again.
And just for the listeners to kind of conceptualize that, it's kind of the idea of, I forget the movie or the research study, I think it was out of Japan, where they studied water and the crystallization of water, when water would be prayed to, or when water would be...
Oh, if you're angry, it changes the water.
And changes the energetic composition of the water, and then they freeze the water, and they're able to tell very distinctly the differences there. They're kind of a similar concept.
I would think so. I think that there's basically anger is an emotion. And prayer there's a certain frequency with prayer that changes things, right? So you're going to see that in the water, or you would see it also in alcohol. So with the alcohol, from my understanding, when I was looking at Galloway's lecture series in the past, is the carbon-carbon bond, which is in the alcohol, is you're able to impart a frequency into that bond. And it holds that frequency. That frequency is then what you take. So when we're doing, remember the original homeopathic things were alcohol based, right?
Oh, okay.
Some of the alcohol based. So there's something in that carbon chain that they were holding on to, is what they figured out. So there's a lot more happening at that sort of atomic, subatomic level that is happening at the energetic level.
Very interesting.
Yeah, I don't fully understand it. I mean, I have to go back to, it's been years since I've been doing physical chemistry.
I mean, I think we may not have the technology to fully measure this stuff, but I think there's been enough, positive results in people from homeopathy or energetic medicine to really.
Right. Well, they're initially called Vol devices, right? So it's called, it's acupuncture. What is it called? It's acupuncture by Vol, I think is what it's called. But it's basically you're doing your acupuncture are based on energy meridians. So we do know energy flows in the body. So if you can find where the energetic imbalance is, you can provide the correcting remedy to that. And that's what acupuncture does, right? To my understanding, that's why you're putting needles in various points, because you're trying to energetically balance the person, right? So the person's balanced, and then technically there should be no disease.
Right.
So these machines find these things, because it says, hey, your knee hurts. So you got an imbalance in the knee. Well, what's that imbalance? Well, you're tending towards arthritis, you're tending towards infection, you're tending towards something. And the machines can do that based on the frequencies.
It's fascinating.
So all these frequencies have to be imprinted in there. And Rife we have a whole book on just those right frequencies. So there's obviously databases that are out there. That's what they're using. So,
what was I going to ask you next? I think, I had a question there. About the emotions. I think we were talking before we started recording, and we were talking about the certain types of emotions that you typically see in cancer patients. Can you talk a little bit more about what those common emotions are and why you think that is?
So what I do is we're trying to find out what emotions people are actually dealing with and what's been suppressed. And so on a common basis, I'm finding some level of shame, embarrassment, shame, something that they're shamed. A lot of them, unfortunately, happen to go back to childhood, where let's say a parent didn't recognize a child, or they didn't feel they were like loved, or had to love my sister more than they loved me, or my father was never around. When he was too busy doing everything else, so they never developed that sense of value. So they're either shame-based, feeling not worthy enough, right? So when you start that way, you wind up with other emotions sort of layering now on top of that. And I'm not saying there aren't. So there's also generational. You go back even further, there's generational things, right? So you can see certain patterns in families. So I'm trying to find what those are. I don't know the patient, I don't know their family, but I kind of start looking, are there patterns? And so the neuroemotional technique will allow me to ask those questions. So the concept of family generational curse, generational patterns. Are those generational patterns unhealthy? Are this patient still carrying these generational patterns? I mean, I'll kind of start digging through all those. I'll dig through their emotions, their own emotions of shame. I will dig through unforgiveness is a big one. I mean, so somewhere they've been offended, they've been hurt, but they've not forgiven that person. And you have to really go back and release those. So I usually refer people to, again, a really good understanding of that. Bruce Wilkinson on YouTube does a video series. It's called 70 times 7. And if you understand Christianity, Christ says, how many times do you forgive somebody? 70 times 7. And he goes into that description, and it's like an 8-part video series that he does that talks about forgiveness and what the importance is and what happens when you don't forgive. So it's kind of an interesting, I have patients go through that, watch the video series, then we kind of start digging through unforgiveness, right? So we look for the shame, the unforgiveness. There's usually fear of their diagnosis, fear of what they've been told. I got to get the treatment. I'm going to die if I don't get treatment. They've been sort of scared into making a decision. And I always tell people, look, if I scare you, we're done. I'm not trying to fear you into that. I want you to make a decision. I want you to own your decision. I think that's crucial. And if patients are really confused and they don't want to own it, let's work on it. It's like, I'm okay owning my health decisions. I'm okay owning the decision I make. What's the block? Where's the block coming from? We'll figure it out, whether it's emotional or not. And then I go through, I'm okay with God. God's okay with me. I have some people have done something that will make them feel like they're not worthy. What is it? Pull it out. And when you combine the emotional centers, the brain, right here, with the meridian, right? Because the energy meridian will hold the emotion. And you find the event. Oh, this happened when I was 7 and this, blah. You connect that to the fear meridian, to the emotional center. They process that emotion. Go back and retest it. Make sure that meridian is clear now. And then if not, we have to go back to first. Is there an additional root to that? Is there an additional cause? Where did the origin of that come from? So that takes at least an hour. The emotion code, I will sometimes, if I get locked, I'm like, I'm not really finding what I'm looking for. The emotion code has a table. And there's columns A and B and rows 1 through 6. And you will find, is there an emotional conflict in row A? No. Is it row B? Yes. It's a column B, row 5. what's in row 5, and then you test those individual emotions out. Oh, bingo.
Mm-hmm.
This emotion, does that resonate with you? Oh, yeah. I've been carrying that around my whole life. Those are the sort of stories we hear. And so let's clear that. And you actually can clear that magnetically. So you run a magnet over the governing vessel, a magnet from here to the tip of the spine. And the patient just processes that emotion and it clears. It's been amazing.
Can you walk me through that? Because so a couple of things I want to clarify. So number one is you're saying testing the patient, i.e. muscle
testing for the emotion, correct.
Okay, which is, for those that are not aware of, I'm sure many people are, but some people may not know what that is.
So kinesiology, muscle response testing. There's some good books on that. I'm failing right now what the names of them are, but there's some books that we
David
use.
Hawkins wrote one, right. Power versus Force.
Power versus Force, that was the one I read. Yeah. But I've taken a few courses in the neuroemotional technique, and that actually was interesting. It was demonstrated on Grey's Anatomy on one of the shows, and there was a practitioner that actually did it and did a really good job. So and actually there's some research behind that. So what they find even through functional brain MRIs is there's a change in blood flow and patterns when you clear something emotionally. So you can actually open up things. So when we're doing that is we simply we show them how it works. Okay. So if I have a patient in front of me, they're sitting right in front of me. I'm testing the arm. I say, okay, resist. I touch here. They get weak. Okay. This is a polarity point. This will show some weakness. Say my name. Okay. My name is George, and they're strong. Okay. Say my name is Tony, and it goes weak. You're not Tony. You're George. So you're going to show that weakness. Then I say, okay, so let me go back and I have them think about something emotional. All right. Think about having an argument with your wife. And they go weak. All right. Think of having a great date with your wife. You guys are out having fun, and they go strong. Right. So now they know there's emotional context to that testing. So then we start saying, okay, do you have a scar? Do we want to go that? Or we ask the concept of cancer. Boom. Well, that goes weak. Is there a concept of emotion attached? Or just put your hand over the forehead. Tested that cancer concept that cancer goes strong. Oh, there's possibly emotion to that. Then we start digging. We dig through the meridian testing. I can dig through body point testing, and then we can find where that emotion is, and then process those out. I find it's an important step to do that because once we're done, we can ask the question: I'm emotionally congruent with getting well, right? Because why do we treat anybody? And why are we going to go through a long course of cancer treatment if you're not emotionally congruent with getting well, right?
I don't think anybody really ever asked that question.
But they should. And I'll tell you why I came to that. Because we were seeing so many women self-sabotaging. Like, wait, that treatment that you got last week worked just fine for you. Why is it not working this week? Why do you think you're sick and it's not working? What changed? Treatment didn't change. Patient changed. The patient changed because the tumors were shrinking and they can't have that. Because there's some secondary gain out of their treatment, out of their cancer. What's the gain? I will tell you, I watch a lady that people will take those traumatic injuries, emotional injuries to their death if they don't want to release them. And you can't change them. The therapy will not work. So I think it's really important to ask that question. Are you emotionally congruent with getting well? And I ask patients, I'm okay with getting well. I'm willing to do what it takes to get well. I want to live. I want to go through treatment. We ask these questions because I want them to be 100% on board. Because once they're on board, they'll own the treatment. If you don't own something, what good is it? I'm just showing up. My wife told me I got to come in today. Go home.
Right.
Come back when you're ready.
Sure.
That's not really a great way to start treating somebody.
What I was going to ask, ballpark here, what percentage of patients would you say, when you ask that question, I'm guessing that's a muscle testing question, would you say are not, willing to get well?
Over 90%. Easily.
Over 90%.
I would say rarely do I find somebody who actually is congruent. Almost everybody will say, I'm okay with getting well. And they'll go weak.
Really?
Yes. Yeah.
That's shocking.
It's shocking, but it begs the question: why? What are we going to do about it? What can you do, and how are you going to fix this? Because if they're not emotionally congruent with getting well, that's the heart injury. The heart wins. the heart and the mind are in conflict, and the heart says, I don't want to get well, and the brain says, well, we're coming in for treatment. I'm sitting in your office. I want to get well. Well, the heart wins.
Mhm.
So we don't need to, I don't want to start something until I make sure the heart's on page, on
Makes sense.
board with the mind. They're working together.
Mhm.
Because then I had a more powerful program. Then they're easier to embrace the treatment. And it's much easier to find out what the best treatment is
Mhm.
if they're embracing it. If they're not embracing it, it's an uphill battle. I get mixed answers. I get all sorts of crazy stuff. And I'm like, this is not working.
Hmm.
Where's the block? Where's the block?
I guess that begs the question too. I'm going to ask you a hard one here. So, I mean, there are so many different causes of cancer, right? Whether that's, multifactorial, what percentage would be, genetic predisposition? What is it is, what of the cancer is, perhaps toxicity? What of it is this emotional component or this heart, damage or, emotional heart damage that you were just talking about? I guess in your experience, what are these main? Is it just a combination of all of the above? Why somebody might,
Right. So I think less than
get the
10% of the cancers are actually genetic.
really.
So, yes. So I think it's environment. If you actually listen to people and you're sort of asking, okay, so wait, you're telling me your father had cancer, your mother had Alzheimer's, your sister has cancer, and you've got cancer, and you're like, where'd you grow up? I mean, what's the common variable? It's going to be a toxic, it's some type of toxin or exposure to multiple toxins that will cause this problem, that will be related to this problem.
Right.
And they won't, a lot of times they won't know. And then when they go back and they'll go and they say, oh, shoot, I lived right down the street from the DuPont plant in Delaware. Okay. That's probably not a great place for off water and all the other stuff that was coming off that plant. I grew up and I moved to Buffalo when I was a kid, and I just heard of Love Canal. I'm like, well, what's Love Canal? Now I'm like, oh, great. We were 20 minutes from a toxic dump. What effect did that have? I talked to somebody else from that area, and they lived on Grand Island, which is across the way from Canada, and there was a nuclear reactor site over there, and everybody in the family got cancer. I'm like, they all got sick. I'm like, you got to start asking these questions because there are some interesting variables. Orange County years ago, they had a lot of these planes that were dumping all this pesticide on these orange groves, and the kids are running after. What do you think they're breathing? I mean, there's a lot of things that we get exposed to, and I don't think it's getting any better. So you got to remember, we're getting all of our grain. Wheat is always loaded with glyphosate, right? And we know that BPA and BPS or non-BPA or BPA free is not any better. Now it's got BPS, and that's just as toxic, right? So, have you been around smoke, secondhand smoke, cigarette smoke, grain? Be a lot of grains in your life. You're going to have mold. I mean, this thing should start escalating. So there's always that variable in there. But if you start throwing in some direct trauma to a body part, that could be a potential trigger. You throw in the emotional issues. I mean, you got to look at this whole thing. I mean, there's multiple little things that come together, and then the endpoint would be cancer. Unraveling, that's the hard part, right? So is there chronic inflammation, chronic lifestyle issues that are not good? There's going to be the toxic issues. Well, I mean, you just go on and on. And so when you start figuring those, it's just that's the hard thing to unravel. That's why when it's not like you have a sore throat, take your antibiotics. This is now work. I tell people that, okay, they're cancer free. I'm like, okay, well, now the work starts. What do you mean? Oh, cancer? No, negative ferret white got cancer. You want to prevent one from coming back or prevent a different one from happening. Now you go back and do the work. Now,
Yeah, I think there's that, component in many people's thinking, not everybody obviously, but that component of, this is just a genetic thing that happened to me. Obviously there's definitely some of that for sure, and that's valid, but I think for a lot of people, I don't know, you know what I'm getting at?
well, I think that's a misunderstanding. I mean, why is it that why is there a rise in glioblastomas and people sit in cell phones like this?
Right.
I mean, there's more to what's going on, and you can't just simply say it's just bad genes. Well, there's something that damaged the genes, right? There's something that's causing the problem. It's not just something, it's your environment. Why cancer rates rising? That all of a sudden, everybody with bad genes just all of a sudden come together and we have, 40% incidences of cancer. I mean, 2 out of 5 people are going to get cancer.
Right.
So, and it's probably higher now. So there's something else going on. And so think back, 200,000 new chemicals were introduced in the 20th century. And do we know what all of them were done? No. And what else was introduced, right? So if you look back, Atkins did a great book. He actually explained that sugar came in the 1890s. 20 years later, heart disease developed. And then he would show you every 20 years, you could see patterns and certain diseases were coming up. We didn't have a problem well, not that we knew it, because we obviously weren't keeping statistics in the 1800s, but honestly, we had grain, right? So white flour, grain developed, right? So we had all this flour. So now all of a sudden we have refined flour and sugar. Well, that's the worst combination. And everybody's addicted to it. So you can't go running around going, my cancer's genetic, when you're running around eating sugar, eating white refined flour. That's essentially moldy. And you're living with someone who smokes and blah, blah, blah. And you're like, hey, hello, there's a little more going on here than simply that. So what I always find interesting is, why is it that several people can live in that environment and only one gets cancer?
Sure.
And why do the other ones not get that cancer? I'm like, okay, so what's the variable? What's something that's different? Is it exposure threshold? Was it emotional threshold? Was it, one was the youngest, one was the old. I don't know. There's still some really good questions I think that we can ask about that.
Right.
But you can't run around thinking, oh, it's just bad genes. It's not more than that.
I think that was kind of my next question, getting into, what are some of the things that are in our control? Let's say, for those of us, trying to do our best to prevent cancer, but then if we already have that diagnosis, what are some of those things? Obviously, avoiding smoking, secondhand smoke, as much chemicals, glyphosate as possible. What are some of these other kind of general recommendations or, things that people can keep in mind in terms of their diet, lifestyle?
Yeah, you can spend a lot of time on that. So, you can't control the air you breathe, unfortunately. I mean, you can try to filter it, you can try to do, but I mean, we've seen patients. I was asked, how close to the freeway do you live and which way does the wind blow? If you're east of the freeway, east of the 5, you're likely to have a lot more, especially if you live close to the 5 freeway, you're likely to have a lot more toxic exposure. So I'm always thinking about, what have you been exposed to and how can you avoid that? So, people live on a golf course, that's not a great place either, right? So a lot of pesticides. So where you live, choices of water, do we drink faucet water? What are we drinking? We drink out of plastic. So I'm trying to get people to get RO water, use maybe some countertop reverse osmosis devices, add your own minerals, right? So you're balancing yourself with minerals. Are you, and then we'll look at your diet. Where's your food sources coming from? But you got to remember, you weren't doing this. If you're 40, you've been last 39 years and you decided you're going to go organic there. That's, what have you been doing for the last 39 plus years and 9 months in the womb? I mean, you have to realize so partly lifestyle issues is like, I want people to have 2 to 3 bowel movements a day. I want them on vitamin C and magnesium to keep those things going, to make sure they have their bowel movements. I want to go back and spend time. We live in a world of biomarkers. Never have we seen so many different labs you can order to know what's going on. Now we have algorithms that put all these things together. And now you have AI that says, whoa, interpret these labs for me. So we have a lot more information that we can get, and we can pick stuff up as we begin to shift energetically. Even we're shifting in a dialysis towards cancer, towards an unhealthy situation. How do we go back? Well, we need to detox on a regular basis, right? So first off, exit pathways, right? Are we sweating adequately? Are we urinating adequately? Everyone is dehydrated. I can't tell you anybody drinks enough water. All right. So a quart for every 50 pounds. And if you're over 200 pounds or trying to lose weight, you got to drink more water. And so I'm pushing a gallon of water, get a gallon of water. And unless you're 150 pounds, okay, a little bit less, but I force a gallon of water in every day. And honestly, now if I don't drink a gallon of water, I'm thirsty. So I will drink a lot of water. So getting the water through flushing the kidneys, sweating adequately, or you're exercising, you're doing some aerobic exercise, we're getting in a sauna. We have people do niacin with activated charcoal and then exercise and then go in the sauna. They're purging their systems. The niacin opens up the fat cells that purges the stuff out of the fat. And then it gets into the system. Well, the activated charcoal's for the liver, and then you drink water, you're sweating it. So make sure you jump in a shower after you're done with the sauna, because you're sweating all these chemicals out. So you have to do some level of detox. I try to keep track of that on a daily basis. Like, what am I doing for detoxing? What am I doing today? I'm going to take a binder today. Am I going to take some, phase 2 detoxification support? Because I know my bowel movements are going, I'm sweating, and I'm drinking plenty of water. So phase 2 detoxification support. Am I taking a powder? Am I taking a supplement? What am I doing? Am I going to do a binder today? Right. So binders, I think it's worth talking about binders. I know there's another product I was just listening to. It's a form of zeolite that actually gets into the bloodstream and sort of cleans up. But most binders don't absorb. Right. So if you take an activated charcoal, a cholestyramine, something, they're going to get into the stomach and into the intestines, but their job is to bind the bile. So the toxins that the liver produce go into the bile. So the liver's detox putting it in the bile gets activated by fat. We eat fat, the bile's going to get activated, right? So the bile gets released in the intestines. The binder's got to be there to bind that up, to bind those toxins up. Otherwise, you're just going to reabsorb. So we want to prevent that reabsorption. So, and then that's also, these binders will constipating, so has the vitamin C, magnesium and stuff to keep you going regularly, right? Or, are you hypothyroid? So we all spend a lot of time as well on balancing hormone systems. So, you're thinking all this detox. If your thyroid's sluggish, your liver's sluggish, your digestion's sluggish, right? So that's going to be a crucial part of your health as well, making sure that these hormones are balanced. So hormones, detox, forms of detox, hormone balancing, and getting into your individual nutritional status, your absorption, right? I mean, can you digest when you're still a young guy, but wait till you start hitting, 60 or a little bit older, you're going to go, hey, I just can't digest as well as that 16-ounce steak isn't quite going to go down as well, So digestive enzymes, other things that you need to kind of help support the digestive process. We spend some time looking at the microbiome, or we just take, probiotics to help cool any symptoms out of there. So I mean, it's just light, somebody said this too. It's like, being sick is hard. Staying healthy is hard. Pick your hard.
Right.
Which one do you want to do? How hard is it? It is consuming if you have a disease to get well, and it's consuming to stay well. So it's like, hey, I would like to do everything I can to avoid having a life-threatening illness, but I would rather spend the time working on getting,
It's a good way to
staying
put it.
healthy, right? So, and looking at screening tests, or looking at things earlier on. So it's like, oh, hey, that's some area I got to focus on, right? So what are we doing? We got to go back and look at all those things, right? So I think it takes a lot of time, a lot of effort. And then again, you got to find someone who's experienced with looking at all this information.
Right.
Because now that the other side, this is just getting you to the point of equilibrium and getting well. What about these people? We're doing, life extension type of work. We're trying to do this regenerative kind of things. We're trying to get us now to live longer and healthier. And that's all doable, right? But it's just, you got to get to the point. You can't just sit there to go do all these other things when you're toxic and you haven't even gotten to just being baseline normal healthy.
Sure.
Right? So I think it takes a lot more time and effort.
Yeah, I think I run into that a lot in patients that I see too. They're looking to come in and, all about the biohacking and the latest, tricks and hacks and everything. But I spend the vast majority of my time doing exactly what you just said, mapping the system out, doing the lab testing, doing the thorough investigation to see where they're at, to just then discover, there's all these imbalances that are going on that you're just, living with unknowingly. Let's just get you to baseline first and then go from there.
Right.
Yeah.
Most people have not that awareness. They think that they're doing fine when they're actually just the frog in the boiling water. They're just deteriorating and they don't know it. Right.
Yeah. It's, and there's a lot of this stuff too. I think unfortunately is not taught in medical school.
None, not at all.
And so it's sometimes it's difficult to find a practitioner too who might be, open and aware. And as a practitioner, I feel like you kind of have to be a lifelong learner to be, truly good at your craft.
Takes a lot of time, correct. And even if you finish your 4-year natural path, correct. So at least you have a different understanding. You're not in a disease model so much, right? So you kind of have a different understanding of where people could go and their potential versus the allopaths that are really in a disease model, right? If diabetes, you take your anti-diabetic medication. If high blood pressure, take your this. You have high cholesterol, take a statin. I'm like, whoa, time out. This is why I got out of this, because we don't want to use these artificial chemicals to essentially cause a physiological change, which doesn't really cure anything, right? So we're mitigating symptoms, but we still haven't found the cause of it. So this is why we spend the time. But it takes the right patient to want to do that.
Sure.
You lose a lot of people along the way.
Yeah, definitely so.
Right.
I think that's a pretty good place. I got a couple. How are you doing on time?
Okay. One area we didn't talk so much about was repurposed medications and why they repurposed. So the medications that have been around for a long period of time are interesting. Some of these older medications they're off patent, they're cheap, and there's just been essentially not being utilized. But they're finding that there's a lot of those that have other benefits. And it's called a redo project. I don't know, I mean, they looked at thousands of medications. So in cancer, there's a lot that can be used. So we're finding, I mentioned sort of half a dozen of them already. We talked about ivermectin, fenbendazole, Claritin, right? So if somebody's under a lot of stress, we can use beta blockers. I mean, there's some physiological things you can do for short periods of time. I don't think this is a permanent fix. People will use statins. I'm not a big fan of statins, but statins can block cancer taking fat. So we'll look at a lot of the work. Jane McClellan wrote a really good book, right? How to Starve Cancer. And then the second sequel to that is How to Starve Cancer and then Kill It with Apoptosis. So there's some interesting concepts in there. And I've taken her online courses and just, but you met her at the last conference we were at. Mitch Genn does some really, really good work in describing what these medications do. So I think there's a whole avenue of agents that we are looking at. We're like, well, could we just judiciously use that without causing so much side effects, but yet elicit a certain therapeutic response in cancer? And I think we have a lot of that. So there's a lot of medications that are out there. And there's a lot of coursework. So now all of a sudden you have a lot of data. So this is like, where do we do with all this data? So now we've got to figure out how to funnel it into useful medications. So
hopefully AI will be helpful. I was just going to ask you about that, where you see, AI in medicine. I'm sure, I definitely utilize it in my own kind of clinical decision making or thinking, just to make sure I'm not, overlooking anything. It's kind of an adjunct to my thinking, not replacing my thinking, but, kind of as adjunctively. Where do you use it, or where do you see AI being very helpful in medicine?
So we can put an RGCC Oncogenomics Plus report into an AI program and say, okay, so what are the best agents based on this report for this patient? And it'll give us some good data on that, right? So I also use it. Jane McClellan came up with about 15 questions that you can ask AI that are very specific. Like, is this cancer driven by glucose? Is this cancer driven by glutamine? Does this cancer make its own fat? Or does it need fat from the periphery? Does it need to take in fat? There's a lot of those questions. And she came up with about 15 of them. And I kind of look back and I go, based on what I know, I want to ask this and this. And another friend of mine, also a naturopath, was asking about even the ethereal, what was the other word for it? But basically it was like more like finding out, like, was it ethereal? I can't remember what he asked. He asked a question. I have the question written down, but he was asking more about what the physical makeup is of this person, and the ethereal, basically more the emotional, spiritual part of what makes this person, and goes along with this cancer type. And then you can start looking at, so what am I looking for in that particular person? But if you ask a lot of those questions, you generate a lot of information and not all of it's practical, right? That's where AI just spits everything out.
Right.
But you're like, well, hold up, that particular research drug is in a study and you're not going to get to that. Or that particular drug is great, but it's very expensive. Who's going to pay $10,000 for a month's supply of some drug? So you have to kind of go back and really figure out. And you're going to wind up with really a handful of things, I think, that you can use to truly pinpoint what we need to do. And a lot of it is we just really pick the healthy ones. So I have a certain cancer supplement, or combinations of supplements that I use that I always put everybody on because it covers so many different pathways.
Maybe let's touch on that, because that's a question I didn't really ask in terms of, we talked about diet and lifestyle. We didn't really talk about supplementation.
Yeah, there's a number of supplements that we'll use, right, for our patients. Vitamin C always makes sense. I like to use a powder-based C. I think it's easy. It mixes in water. It tastes good. I'm always about how do I really practically get this stuff into people. I use a lot of melatonin. I think melatonin has cancer, basically immune-enhancing effect, anti-cancer effect. It's also chemopreventive, so it prevents chemo side effects. I mean, the list goes on for melatonin.
Low dose, mid, high dose.
So we're looking at high dose. I know that people have used super high dosages into the 1,000 milligrams. I'm like, I just don't know how much of that's actually getting in there, how it absorbs, or if it actually, they're using a lot of times creams. So I don't know, because I haven't really ever done a melatonin level, but I would know just from overall, I try to get people up to 300 milligrams orally. There's a lot of good data for that. I put almost everybody on some form of sulforaphane or broccoli extract. So we use Brad, which is from New Sin Life. It's a powder. It's been naturally desiccated, and it's with radishes and broccoli, and it has just a lot of that sulforaphane. I don't know how many heads of broccoli you think I want to eat a day, but
I actually grow my own broccoli sprouts. I tell a lot of patients to do that if they're willing.
Yeah, if you're willing to do all that, right?
Yeah.
So that's a lot of extra work. I mean, yeah. So I have them on the melatonin, the broccoli, modified citrus pectin. That also detoxes heavy metals, blocks galactin-3. I have them on some form of methylation, dimethylglycine or trimethylglycine. I use the Velasta oil, but I'm thinking I might shift it to vegan DHA because it's liposomal. Because a lot of these things don't smell good. Like the Brad doesn't smell great, but I mean, if you can mix it and find a good taste to some of this stuff, it's doable. I like the powders because I think if you mix it with water and sip it, you're always dosing yourself with something, right? So that actually is, and I don't think if you just take a large amount of it at one time, you're going to get all of it in. So. So I'll spend time with a lot of that. Everybody needs to be on B vitamins. Vitamin D, we want vitamin D levels at 130.
Really?
That's not toxic. It's not toxic. Right? So toxic is really when you have clinical symptoms. You don't develop clinical symptoms at 130. I've seen people at 250 without symptoms.
Really?
So this whole misnomer about vitamin D toxicity is really wrong. It's actually, they're not toxic, and you can easily get them to 130. I keep mine at 110, 120. 10,000 units a day. There's no one less than 10,000 units a day.
Really?
Yeah.
Because I guess in clinical practice, I've always recommended people, not necessarily cancer patients, but, just general population, typically anywhere between about 60 to 90 in that range.
You could have gotten that because, 300 years ago, people were outdoors more and they were outside getting the sun, and you can maybe get those levels that way. But right now we're indoor, we're exposed to a lot more things, artificial light. We don't get out enough.
Oh, for sure.
And we are exposed to a lot more challenges in life than we're ever exposed to. Think of the EMFs, think of exhaust, car exhaust, think of the toxins, think of all the things we're exposed to that no one was exposed to 200 years ago. The body's like, oh, what's going on? So I think the vitamin D levels kept a little bit higher would actually be more therapeutic.
Interesting.
Yeah. And then even vitamin A, we ignore vitamin A. All the fat soluble vitamins, K, E. I mean, all those things are beneficial. So I like to run a lot of nutritional testing. So I'm like, hey, what are you missing? What are antioxidants are best for you? What could you take to get your body healthier?
Wow. Yeah. There's a lot to it. But
I've been working on it for 20 years, and I still think I'm on the uphill part of the escalator,
Mhm.
still trying to learn more and figure out more. I don't think you got to really realize you don't always have all the answers, and then you get thrown a few challenges, and you're like, okay, really, now I got to go back to really figuring this out. So, you know, I always think it's just very prayerfully addressed. Lord, help me with these ants. Help me taking care of these people. If you send them my way, please give me some answers. So
Definitely.
it's got to be a way in which we can help. God can really impart, I think, a lot on us, and so I really rely on that too. Right.
Incredible. And maybe on that note, what are you currently most excited about in clinical practice? And then to follow that up, what are you most excited about in the horizon in the next, 5-10 years of medicine these days?
Hard to say. I'm trying to find ways to put a lot of this information together because there's so much wisdom from the past that we bury. And I'm trying to dig it out. But I know that cancer's changed. Cancer 70 years ago is not what it was today. Not what it is today. I think it's more complicated. I think it's more aggressive. And I think that we have to think about it a little bit differently. So I'm always trying to figure something out. And how do I make use of all the tools I already have? Right? Because it gets sort of frustrating. You're just getting new machines or new devices. And you're like, now where do I fit this in? So if we can isolate it down and utilize what we have and learn, right? Because we don't learn everything all at once. You learn in the layers, right? You go back. I got the basic understanding. Okay, let's go back. I got another understanding. Okay, let's go back 3-4 times. And you're like, oh, I can get a lot more out of what I'm using with these particular things, these combinations of things. So it's really trying to figure this out and then being able to implement it. But I also find that you can't get through the mind until you can get to the heart, right? You got to get through all these layers. So there's even I think it was Steigler was a German guy that anthroposcopic medicine, developed anthroposcopic medicine, and he was in Germany in the 1800s. And he described 4 bodies, right? The spirit body, the soul, the energetic body, and the physical body. And the immune system sits between the upper 2 and the lower 2. And the immune system is totally sensitive to thoughts, emotions, and to the environment. Right? So, and in the physical body, they describe the spiritual part is disconnected from the physical in cancer. Well, now we came to that understanding. How did you figure that out? And what do you do to fix that? So I think there's just so much more out there that we can really would like to learn. And I really think the next part of that is getting that taught to practitioners, right? So I kind of don't really rely on the allopaths. I don't know that unless their way of thinking and the way in which they do things changes, can you really educate an allopath? And I've tried a few nurse practitioners and PAs, and I find, wow, this is really hard. You guys don't even know what an organic acids test is, right? So the naturopaths, the chiropractors, they're like, okay, we kind of got these pathways down. We understand these metabolic things. We understand nutrition. We understand organic acids and all these different tests. And like, okay, so those are the people you can work with to take them to different. How do you interpret that? What do you do about this? I think the naturopaths have more of an understanding, but they don't always get the good foundation in internal medicine. That's you almost have to know the pathology. It's I've gone a long way to come back to where I am to look at this thing. And I'm like, wow, this is so education 30, 40 years ago in medical school. I'm like, man, I still fall back on that. The good internal medicine, seeing these sick people in the hospital. I'm like, man, you really fall back on okay, we're still, how do you figure this out? And then there's all these modern advances. So you just have to keep learning.
Yeah, that's one of the drawbacks of naturopathic medicine is, it's, I feel like a very similar first 2 years of school in terms of the pathology, physiology, biochemistry, et cetera. And then there's a divergence in the last 2. And then, we're not required to have a residency. So we don't get those reps in that you guys do, just so many patient visits and the rotations and all that. That is something that we're definitely missing out on in our training. But yeah, I think pros and cons, right? More open-minded, generally speaking, in terms of all these different modalities and different ways of thinking, and not, relying on pharmaceutical intervention as our kind of first intervention, if you will. So yeah, hopefully we'll be able to meet in the middle at some point.
Yeah. Well, again, you're still learning. You're still going to conferences.
Right.
I mean,
Always.
I go to more naturopathic conferences, right? There's one coming up right 2 weeks, right? The AAMP, Paul Anderson.
Yep.
Love him.
Yep.
Great material.
he's
Listened to him
great.
a dozen times.
Yeah.
So I think there's a lot still can be learned. But I'm just always interested and impressed on what he comes up with.
Yeah.
So
Paul's a great guy.
yeah, Paul's really good. So
Well,
thank you for doing this. And, I hope you have some material you can use, and
I'm sure
where
we
it goes.
will.
Yeah.
And before we sign off, just tell the audience where they can find out more information about you and your clinic, and if they want to become a patient, how they would do that.
Okay. So we have a website, Quantum Functional Medicine, QFMED.com. Easy to find. And then there would probably the easiest way is either you can online fill out, some information intake, and that gets sent to the front desk. You can call the office. There's 760-585-4616 is the phone number. And info@qfmed.com will also get to me or to my associate. So we can then screen what people want. So, and then we'll reach back out to you, and then we'll figure out what we do to book an appointment.
Amazing.
So yeah, a lot of these are cash-based. These are all cash-based visits. We just have not figured out a good way in which insurance companies will pay for this kind of model. We tried that. There is a few clinics that have actually managed to do it. We weren't able to. So we had Carlsbad Integrative Medical Center was our other clinic that we were trying to do on an insurance basis, and we just did not set it up right. So that did not go.
Yeah.
So we tried.
Yeah.
I don't know that I want to lose that much more money.
Sure.
We'll go back and do that. So, yeah.
Well, Dr. Winkler, you are a powerhouse, a force for good, and
I appreciate
got a
it.
tremendous amount of wisdom. And so thank you for really.
You guys, thank you for setting it up. Really appreciate it. Yeah.
Definitely so.
Yeah.
Definitely so.
All right. Thank you so much.
Thank you.
All right.
I just want to say thank you so much for finding us. We're building a place to talk everything cancer, and since we're just getting started, there's one small thing that you can help us grow. Hit the follow or subscribe or review or share button or whatever button wherever you're listening. It really helps this project reach more people who might really need it right now. On top of that, tell us what you want to hear about, and we'll do our best to deliver. By the way, we share perspectives and stories, but never medical advice. So please talk to your medical team for guidance.